Today our workshop title is What is Cancer Medicine? And we have Hoa Duong. He's an MD and a hematologist and oncologist at Kaiser Permanente. So let's give him a round of applause.
Okay. So, I've been practicing oncology for about 10 years now, since 2005. I've been with the Kaiser Permanente group for the same amount of time. Um, so, so everybody here is interested in medicine, and everybody here interested in oncology, maybe. All right. So let's have a roadmap then. Let's map out the step to go to to become a clinical oncologist. So I finished my undergrad in 1990, and after that, there were 4 years of medical school, and after that, 3 years of residency in internal medicine, and then after that, there about 3 years of just practicing medicine, and then 2 years of practicing hospital medicine, and then 3 years of, following that with 3 years of fellowship in oncology and also hematology. So in general, it takes about 10 years to go from completion of your undergraduate degree to being certified as a hematologist and oncologist. So that's more or less it. But I'm open to questions. So anybody have any question regarding, how to go from undergraduate to get into medical school, what to expect when you're in medical school, how to go from medical school to a internal medicine residency, how to go from a internal medicine to a oncology fellowship, and then what to do after you finish your fellowship and start practicing oncology, and what your day-to-day work is like. We can talk about that. Yes?
What encouraged you to pursue oncology?
Oh, it's scary, you know. When I was practicing primary care, I saw all different type of illness, but the thing that scared people the most at that time was, cancer. So that kind of scared me too, and I thought about so I decided to kind of learn more about it, because I did my internal medicine training at UC Davis Medical Center, and we didn't have a lot of exposure to oncology. So when I finished my internal medicine residency, I didn't know much about oncology. So that's why I decided to learn more about it. Yeah. So, yes?
What made you decide to work for Kaiser Permanente instead of something like academic medicine?
Yeah, there's pluses and minuses of different, well, let's step back a little bit. So there are many ways you can set up your practice. You can set up your own practice. You can be a oncologist, and you just run it as a business, basically. Or you can join a group of other oncologists and work in a group practice. Or you can join a big medical group like Kaiser Permanente or Mercy Healthcare, now Dignity Health or Sutter Health. And then you can also be in academic. So in academic, there are other responsibility in addition to just taking care of patient. Some of that are training the new fellow, training residency, and teaching medical student. Some of them are administrative. And I wasn't too interested in the administrative aspect of it. So I didn't think I would like practicing in that environment. For Kaiser Permanente, when I was a residency at UC Davis Medical Center, we actually went to Kaiser in Sacramento to train as well. So I get to meet some of the oncologists there. So, I want to join a group where I get along with other people. So that's why I decided to join the Kaiser Permanente group. In addition to that, I also have some opportunity to talk to a resident and fellow and medical student. But I don't have to do too much of the administrative work unless I want to. So that's the reason. But different fields are different. So everybody ready for the MCAT and the medical school application and the medical school interview? And I saw that workshop out there that actually show you how to do those things. Yeah. Yes?
Where do you see cancer medicine heading, and what would you suggest us to do as
Yeah.
students?
I think cancer medicine is really, there's nowhere to go but up, simply because we don't really know very much about how a cancer cell work, how the cancer cell grow. We're starting to learn, and we're starting to have tools to learn how to do it. And the reason why it's so difficult to learn, I think, is that we did not have a machine to allow us to process so much information, at a short period of time until now, when we have big computer and faster computer. Because when you think about it, we just discovered about the DNA in 1950, Washington Creek. So that's about 60 years ago, and we just mapped out the genome, 20 years ago, actually 15 years ago. So then the next step would be, all the different proteins that are made by these, like the DNA, and how they participate in how the cell grow, how the cell die, and how they interact with each other. So, so that's a lot of information to process. And I think once we understand that, then we can understand, when it goes wrong, And then when we understand, when it goes wrong and how it goes wrong, then we can try to fix it. So that can take, that take a lot. So there's a lot of work to be done, and it's gonna involve a lot of people with different skill set, So it's pretty wide open field. If you go in math, you probably will be okay in, oncology if you're good. So, yeah.
So this seems like cancer medicine will be needing MD, PhDs more than just pure MD, because there's a lot of research involved.
Yeah, I don't think you need degree. I don't think you need numbers, like letter after your name. But I think you need to have knowledge, right? I mean, you can have knowledge without having the degree, right? And as the same token, you have the degree without the knowledge, right? So I don't think you should limit yourself by what kind of degree you have, But with that said, though, I think when you apply to medical school, they tend to look at, they tend to pay more attention to people who have expressed some interest in basic research. They tend to look at people who have done some kind of, project during the undergraduate year. They tend to look at people who have published some paper in the undergraduate year, and that's part of the academic medicine too. Yes?
So, as an oncologist, I feel that perhaps more than a lot of the other medical specialties,
Yes.
you interact with the surgical specialties, and I was just wondering how that kind of plays. Like, do you tend to decide on a course at the beginning, and it's mostly dominated by one of the two, or do you find yourself either collaborating very closely or kind of switching back and forth?
Yeah, it does take a group. It does take a surgical oncologist. It does take a radiation oncologist, somebody who uses radiation to treat cancer, and medical oncologist, and other subspecialties as well. We have a pretty regular meeting every couple of weeks or so, and then we discuss some of the cases, and then after that, then we can try to figure out what's the best thing to do for the patient. But yeah, so we have so that's another advantage of working in a large group, because you know each other really well. You know each other's tendency well, you know. So yeah, we do have discussion like that, so that's the advantage of, that's the disadvantage of if you are you have your own practice. Yeah. So. Yes.
What kind of cancer do you encounter the most?
Yeah, I think just like more commonly for women, it's breast cancer. For men and women, it's lung cancer, and colon cancer. So mostly, solid tumor. But our role in those solid tumor is actually not, it's secondary, so it's not primary, because those tumors are still curable. You can only cure if the surgeon can remove it. At this point, if the surgeon can't remove those kind of tumor, we really can't get rid of it completely. So our role in there would be, in those type of tumor, would be just to use medication to improve a person's chance of surviving the cancer after surgery. There are a lot of problems with that, because one, there's no way for us to tell at this point whether somebody has surgery to know whether they still have cancer or not. And then secondly, there's no way for us to tell whether the cancer they have, that the chemotherapy or the medication we're going to give, we're going to work or not. So we may run into problem where we may be treating somebody with something they don't have, or with something that's not effective. So the work that people should do in that case would be try to figure out if there's some way to find out if somebody has surgery, or even before surgery, right, to see whether they have cancer confined to one place or elsewhere. Because if you have cancer confined to one place, then the chance that the surgeon can remove everything. And if you have cancer already involved more than one place, then there's no reason to subject that person to have a surgery, because you know you can't really get rid of it. And then if somebody can figure out a way to predict ahead of time whether the medication we're going to give will work or not, that would be extremely helpful as well. Right now we have statistics, would give us some information, but really not enough. Right now what we have is that if somebody have cancer, they will divide those people into different groups, in general based on the size of the tumor, based on whether it confined to the organ or have spread to other, to the lymph node, for example, or the other part of your body. And then based on that grouping, they call it staging. You heard that. They decide, what the percent of these people will have cancer, will die from cancer, let's say in 5 years. And obviously, the higher the stage, the number is higher. And then the next thing they do is they will divide the people into two groups. One group gets some treatment, one group do not, and you see that the treatment make a difference. So statistic, the difficulty with that is that we don't have a mean to, because when you divide tumor into size, it makes sense to the surgeon, right? But really for us, it doesn't make any sense, because in order for the medication to work, it had to be directed at the cell. So let's say two women may have breast cancer, but they may have different type of breast cancer from a cellular level. So one medication may work for this person, may not work for the other person. We know that, but then why would you just treat everybody with breast cancer with the same medication? So that's the next step we need to sort out. So at that level alone, you can see we still need to do a lot of work, right? Because right now we're treating a lot of people who really may not benefit from what we're doing, The other, for the common cancer, the other time when we get involved is when they get to the point where you can't get rid of the cancer anymore. So you hope that you kind of control the cancer for a while, and you try to help them deal with the complication related to cancer. So that one we involved near the end. So that sometimes can be very difficult, but yeah. So, yes.
What's the most rewarding aspect of being an oncologist?
I think you feel like at the end of the day, you're useful to somebody, you know, that you help them even you just help them relieve a little bit their pain, you know, you feel somewhat useful. Um, so obviously, occasionally when somebody who come in really sick, and you're able to get them better and get them back to where they were before they got sick, then that's really rewarding. But it's tough because you really have to maintain a very even keel, you know, because you get too excited when somebody do well, you may get into really, you know, run into difficulty when somebody doesn't do well, you know. But you learn to celebrate every single small victory, you know, and then, but yeah, I mean, a lot of people think that oncology is depressing. I'm not sure if it you know, more depressing than anything else. I think it just depends on how you look at it. You know, it may be depressing if you just spend all your day in a dark room looking at film. You know, like a radiologist. That can be depressing, right? Right? It's difficult, yeah, but it can be rewarding. Yes.
You spoke earlier about administering treatments that are not always helpful depending on which kind of cancer a patient has.
Right.
So what kind of conversations happen with the medical team to discuss if maybe that patient should just not receive treatment if it's not going to be helpful, if that treatment will have some negative repercussions in terms of like exhaustion, etc.?
That's a good question. I think that had to do, well, there are a couple of things. One is we can't tell for sure if something is not going to be helpful, right? We can say that, you know, it had been used in the thousands of people before you, and the chance of helping these 1,000 people was zero, right? But the person may say, well, maybe I'm the different person. I'm a different type of cancer, and maybe this thing may help me. So you can never say with absolute certainty that what you're going to do is not going to help that person, right? So that's difficult. But what you can say is that, okay, the procedure, the potential harm it can do to your body, the potential good it can do to your body. And then some people will say, well, you know, I really don't want to accept those kind of risk. And they will decline the treatment. But then there are the people that will just keep on pushing. And if they keep on pushing, and because you don't know for sure that what you do, you know, that person may not be helped, then you tend to do to treat that person anyway. I mean, a perfect example, you know, you have all these famous people, right, with cancer, and they're doing all this procedure that, in retrospect, really didn't help them at all, right? So again, it go back to, you really have, you can't just base it on statistics. You really have to understand how cancer cells work. And that when you make a big difference. Because in our history of treating cancer, the time when we can make a difference is when actually have a better understanding of the cell. For example, there is a very peculiar type of leukemia called promyelocytic leukemia. And the way we describe that is mainly description, because all our cells grow in the bone marrow, and they go to different phases to go from a very immature cell to a very mature cell. And then for some reason, there's this condition where the stem cell keep on making new cell, which is not supposed to do. And it gets stuck at that level, what we call promyelocyte. And before we have a better understanding with, the survival rate is really pretty much near zero. And the reason is because of these cells, they have so much of it, they release substance into your blood that make your blood clot and make you bleed at the same time. So people will die because they have bleeding into the brain or they're bleeding into their intestine. And then somebody discovered that in these leukemic cells, they have a part of their 15 chromosome moved to the part of the 17 chromosome. And then somebody dig deeper and say, okay, well, the reason for these, when the consequence of moving the 15 chromosome to a 17 chromosome is because you have this retinoic acid receptor, kind of similar to medication that we give for acne, that somehow stop these cells from growing further. So the way to get around that is to give medication, retinoic acid, to help them overcome the blockade and allow them to mature normally. And when we do that, the survival rate now is pretty close to 90%. So, again, if you understand how the disease works, then you can make a big difference. But until then, you just hope for the best. Yeah. But you're right. When somebody asks for something and they understand the limitation of what we can do, but they're willing to accept any risk, it's really difficult to say, no, we can't do that. So. Oh yeah.
What are your thoughts on cancer patients using medical marijuana to ease their?
It works. Yeah, and some people work really well. Yeah, so because for cancer, there are a couple of things with cancer that common to most cancer is that somehow they make a person cachectic. It kind of take away that person's appetite, and marijuana is pretty good appetite stimulant, so that works. Then with chemotherapy, that can actually depress your appetite as well, and that can also make you feel nauseous. And some people, marijuana work really well also. The trouble you run into sometimes is that you have people in their 70 or 80 who have never tried marijuana before, and their children will ask them to try it either in liquid form or in cigarette form, and they will have a really bad reaction, a bad trip on it, and they don't like it. But yeah, in general, it works pretty well. Yeah. I mean, that's something we occasionally use also. So what year are you in general? Are you first 2 year or the second 2 years? The first or second year or third and fourth year? First and second year? Oh, okay. So you have some time to work your application and everything then. Cal Berkeley? Yeah. Exactly, go there. They didn't do too well yesterday, but it's a football team. Yeah, so undergrad and graduate school are so vastly different. It's really depressing. When you get to medical school, because undergrad you tend to pick class that you like, and then pick class that you want to learn. As soon as you get to medical school, it mainly just one class after another, after another, after another, and it wasn't. It basically just somebody tell you, okay, these are the things you have to memorize, and and then after a couple of weeks you take the exam, and then that's it. For the first 2 years anyway, and it was kind of difficult for the first 2 years. The third and the fourth year, when you actually get to meet patients and talk with them, then it get better, because then you start. Because the first 2 years really devoid of any creativity, devoid of any thinking. It's not learning really. But the second 2 years is when you start facing a problem and you try to work that out and to solve it, and that way it's more fun. Yeah. And then when you start residency, that can be tough, especially the first year, because then that when you have your you're able to order the nurses around and tell them what to do. And then when you have the potential to harm somebody, it's kind of like getting to drive the car the very first time. And then but then that's how we learn, and you try not to make a big mistake when you learn. But then again, for oncology or any career in medicine, really, you can't really stop learning. you know, because it's an ongoing process. Even, you know, from day to day, there are new things that you need to learn, you need to know. Because if we stop here, then we're in trouble, right? Because what we have is not very good, you know. So, but that, I guess that goes with anything really. So, but it's a rewarding field. It's a big field. It can use different people with different skill set, you know, anywhere from basic science research to clinical research to talking and taking care of people, patients. And it could be in the academic setting, it could be in the large group setting, and it could be in a small group setting too. Although we see that less and less, I think in the overlying area, then you may have 1 or 2 oncologists that practice by him or herself. But in large cities, usually you work in a group. Typically, again, it takes a group of doctors to take care of one person with cancer. You know, it's not something that one person can do, you know. So, but, you know, I'm hopeful. I know that it's gonna change 10 years from now. If any of you know, gonna finish your fellowship in 10 years from now, the way we take care of people with cancer will be vastly different than what we're doing now. You know, we start seeing some changes in small group of cancer, but I think one would understand things at the cellular level in solid tumor and also in blood disorder, then we can make big changes. Yeah.
The medical profession is very rewarding, but there's also a lot of sacrifices you have to make.
Yes.
Can you elaborate on some of the sacrifices you've had to?
Yeah, I think the toughest thing is time. So you know, in medical school, you have, I think 2 weeks. I had two weeks off maybe between first year and second year, and then there's really no time off between second year and third year because there's that break in between when you to take the USMLE step 1 or step 2. I don't remember now. It was so long ago, but it meant it's time. So that's why I think most physicians end up marrying each other, too, because you know they don't have time to go outside of their career. Or most physicians, you know, marry nurses or the other way around. But the key thing is time, and it's okay when you are without a family, when you're single. When you have family, it's a little bit harder. But you know, I still don't know how to get around that. I find balancing between what I do at work and at home. My wife is very understanding, so that's helpful. But it's still tough. But you know, but on the other hand, is there any career where you don't have to, you know, make any sacrifice? I don't know. You know, it's a matter of what you want to do. So I think, but the other thing about cancer medicine is that, so it teaches you to be more patient, and it teaches you to be more tolerant. It teaches you to appreciate life more. So you don't take things too seriously, you know, because how bad a day can you be, you know, can you have, right? When you see somebody who, you know, have pain and who dying from cancer, who, you know, there are people who are but you also meet really amazing people as well. People, because that's when you really find out how, you know, how people really are when they're faced with some, you know, adversity, you know. I have one patient who 30 years old, and he was diagnosed with a brain tumor. And even though the surgeon tried to remove as much as they couldn't remove everything. So he had to have radiation typically. the surgeon couldn't remove anything. So the way we give radiation is that it's a external beam radiation. So you shine the beam of radiation from the outside, and the particle will go through your skin, go through your bone, and go to the tumor or where the tumor was and stop there. So very important that you actually have to aim the beam correctly. So one way we do that is we take a imaging of the tumor on the brain, and then you try to mark the beam, where you aim the beam. And in order to aim the beam, you actually have to make 2 small tattoos on your skin, so you can, each time they go in, you can actually aim the beam radiation right there, So after he finished radiation, a week later he came back, and instead of 2 small green tattoos, he had 2 big eyes on the back of his head. And I thought that was pretty funny. He said, now I have eye on the back of my head. So humor, sense of humor helps, And then you don't take things as seriously as you used to. Big things, they don't seem that big anymore. So there's some advantage to that. But so.
How do you prepare yourself for some of the tough discussions that you have?
Yeah, you try your best. You run through your conversation in your head, and you kind of try to predict how the person will respond, and you try to kind of think ahead of time what concern they have, whether for their, some people worry about whether they're going to be in pain, they're going to have discomfort, what kind of discomfort they have. Some people worry about their family, what their family going to do. One advantage we have is that a lot of time we get to know the person, or disadvantage, when they have cancer, but not before they get really, really sick. So then we get to know them pretty intimately over the length of their illness. And that varies from anywhere to several months to several years. So during that time, you have talked to that person enough that you have a sense of what that person, priorities are, and then back to her question is that you have a sense of how much risk this person is willing to take, and because we all talk about quality of life, but that's different from different person, So when you get to know them well, then the conversation is not as difficult in the sense that you don't know what to tell that person, but it's difficult in the sense that you're about to lose somebody that you know so well for so long. So what do you think, what are you doing now if I'm preparing for your application or your medical school? Is anybody planning to take a year off between undergrad and medical school? Yeah.
What's your opinion on taking a gap year?
Huh?
What's your opinion on taking a gap year?
The gap year, you mean like a year between? I think that's a great idea. I wish I were able to do that. I didn't. I was in such a hurry. I okay, I finished this. The next step will be this. The next step will be that. So I have everything mapped out. And in retrospect, so I didn't take time off until I finished my internal medicine residency. But I really didn't take time off either. I just started working. Without knowing exactly what I want to do. But yeah, I think it's a great idea. I think people that take some time off to kind of re-examine their life, and then when they start medical school, I think they know very sure that they want to do it, and they tend to be, well, to me anyway, they were a lot better adjusted than I was, and they handle things a lot better than I did. Yeah. So, and then the another advantage to that as well is that I'm not sure how much medical school costs these days, but because there's that length of time between you finish medical school and the time you get a real job, the interest on your student loan can be a lot, you know. So some school, let's say outside of state, require to be in that state for a year before you can get the in-state tuition. So some people I know did that. They will go to Nevada, Reno, live there for a year, and they will apply to University of Nevada, Reno, and then the tuition is lower. So that's the other advantage of that. Or you can just go travel and explore, you know. Because once you start, it's really hard to find time to do anything else.
And also looking back at all your experiences, undergrad education,
Yeah.
med school, everything, would you do anything differently?
Oh. Probably not. I mean, I remember during residency, that was back in the early 1990s, and that was during the first internet boom. A lot of the people in residency, they were talking about how, they should have gone to computer science and electrical engineer and stay there, and they would be able to retire by the age of 30 or 40, But yeah, I'm not sure I would do anything different. I'm pretty happy where I am now. That doesn't mean that the job is easy, That doesn't mean that you have days that you're sad, But in general, at the end of the day, you feel useful, and that's not a bad feeling. Yeah. So. Yes.
Did you have any sort of like defining moment or experience that like led you to pursue oncology?
Defining moment. Not oncology per se. Although my mom died of cancer when I was 16. My dad died of cancer after I finished my oncology fellowship. But all of us are touched by people with cancer. But I don't think there any one defining moment that say, this is what I have to do. It's just a matter of, I was seeing my patient diagnosed with cancer and just seeing how hard it was for them to deal with and how hard it was for their family member to deal with and how scary it was, And I wasn't really equipped to help them with it at all. And then if I make a referral to the oncologist, then the oncologist usually take care of that person. So I thought, well, maybe I should learn how to take care of these people better. Yeah, so. But there isn't a defining moment. But oncology from a scientific or from a science standpoint, it's very fascinating, right? I mean, it's the observation about life, right? How the cell grow, because the cancer cell is no different than a normal cell, A cancer cell grow like normal cell does. A cancer cell move from one place to another like the normal cell does. So it's really not different. But yet, how does something so similar, to a normal cell can cause so much damage, right? And make it so difficult to treat. And then from a practice standpoint, from a clinical practice standpoint, pretty rewarding as well. I mean, you meet people in that really more difficult time, and you get to learn from them as much as you try to help them, and it helps you deal with things better, in general. So. It does take 10 years, but so pace yourself. It can go by fast, and you learn new things every day. And when you're done, assuming that you don't have a big, student loan, and I think you'll be financially okay, and your family will be okay also. So you can't ask any, I don't know, I guess you can ask for anything, but it seems kind of greedy to ask more than that. So, yeah. How much does it cost now? Do you really know, like to go to medical school?
Hundreds of thousands.
And what's the interest rate now? Like 6-7% or something?
Something like that, no deferment.
Oh,
You
gee.
start paying interest even while you're still in school.
That's so unfair. You know, no, really. Right? Because you have people that you know are going to be so good, right? And they're not going to do it just because it makes no sense for them to do it. They can't do it. And that's not fair. And we see that in oncology now too, because although we have new drugs, they're so prohibitively expensive that some people actually do the opposite. That we can tell them this medication may help you, but they may not take it just because it's so expensive. And that kind of distressing too sometimes. So I guess somebody needs to reform the medical education system and then the healthcare system. But good luck with that. Yeah. I'm pretty lucky that I went through medical school when I did. But yeah, I can't imagine, how people can go to medical school now.
How much did medical school cost when you were a student?
I see, undergrad was, I don't remember now, maybe like 5,000, 7,000 a year or something. But then again, that was 20 years ago. If I bought like Microsoft stock then, I could retire now. Oh, I don't know. Yeah, it's crazy expensive now. Yeah.
If you were to have taken a gap year, what would you have done during that time?
Did what?
If you took a post.
Oh yeah, I probably go teach. Yeah, I went to a medical school interview, and among so many crazy questions they ask you, somebody from I think Stanford asked me, "Do you write your personal statement yourself?" I said, "No, I hired somebody to do it for me." So I said, "Well, what would you do if you didn't get in?" I said, "Well, I try again next year, I guess." He said, "What about if you didn't get in you don't get in the next year?" I said, "Oh, maybe I become a teacher." But yeah, ask you all the crazy questions. I remember at UCSD, the one person said, "So what textbook do you use for your internal medicine?" And they're basically the two, one is by Cecil and one by Harrison. You don't need to know that still thing. I said, well, in medical school, we use Harrison. Some people use Cecil but didn't like it. And it turned out the person interviewed me, he wrote a chapter on nephrology in the Cecil textbook in internal medicine. So again, that was the wrong answer. But how will you know, right? So just be prepared for anything,
What question would you ask?
Oh, I interviewed a medical student, actually undergraduate student before for medical school. I don't think I'm that mean, I just asked, I think I tried to kind of see if they're prepared for medical school and see with that remaining time what the best way to spend those time before they start medical school. But more a conversation than the interview or interrogation. So I don't have any, they have a set of questions, they tell you to ask. And then at the end, you always ask, they always ask you, oh, do you have any question for us? And don't ask, don't ever ask them if they think doctors are making too much money. I don't think they're like that. But so no, I think once you get to the interview part of it already, then all the score and everything else really doesn't matter very much. It just matters whether you, by chance, you happen to meet somebody who likes you, and because the person who interviewed me was a pediatric surgeon, and he happened to work at in Thailand in the refugee camp, and my family stayed there for a few weeks back in the 80s, so we just talk about that. So so we happen to have a connection, and it made things a little bit easier. But it's just random, I think if I then advise, I would say try to minimize your tuition as much as you can, if possible, because the degree, a medical degree from any school, is really no different than anything else, any other school. And the last thing you want is to go to a quote unquote, high-ranked school by the U.S. News and Review, and then end up being stuck with a big bill, and then you can't pay for it. Because the people I work with now, some of them from, quote unquote, big time school, that I really question how they think, I do. And then some of them from, not so, big time school, but they have more common sense and they're kinder to their patient. So I wouldn't put too much weight on which school you graduate from. It's not like undergrad. Undergrad is a little bit different, but it's different to graduate from UC Davis, let's say from other school. But for medical school, it really doesn't matter because the information you get will be the same. Half of what they're teaching you would be wrong anyway. You just don't know which half until you start practicing. It's a well-known fact, actually. But yeah, and then if you don't have a big loan to pay off, then you can go for specialty that would take 6-9 years to complete, like pediatric cardiothoracic surgeon, for example, or pediatric neurosurgeon, and not having to worry about having to pay a loan that's so big. If that's something you want to do. But because I see really good people, again, not able to do the thing they want to do because they just can't imagine to carry that loan for that amount of time. Right? And you have all this program where they can pay off your debt, like the armed forces or the public health service. But if you're a neurosurgeon, where are you going to go to work at public health? You can't just go to some boony and set up your neurosurgery suite, or an oncologist, right? So, and then the second thing is, I think if you have done some clinical research work during undergraduate year, then I think your application will be a lot stronger than we didn't. And I think the advantage of being here is that you have an opportunity to do that. Yeah, so, okay, well, good luck. And